Can everybody see the words direct primary care?
Yep.
Yes.
Oh, perfect, perfect. Okay, I'll go real quick. I just did this for the ACLM recently. Let's see if I can do this. So I'm going to skip a lot of these. And again, Wayne and Joe is on the call. Again, the lifestyle medicine is really where I was focused on. But this kind of gives you I did a really good comparison about fee-for-service and direct primary care when it comes to how we're delivering care and what are the differences for a lot of people who really don't understand direct primary care. And basically what it is, the most significant note to this, and Joe, obviously, Joe Grundy, we would, is a huge person in this movement and keeping the information out there for other docs and other systems to understand. But the big focus for direct primary care is there's no third party. It is deliberately direct. And what we continue to look at, as we all know when we talk about quality, especially what Larry was talking about was the focus on design thinking, is what are we designing for? Who are the stakeholders? What are the pains? What are the gains? And then we have to answer those questions. So if you use the design thinking, which is a human-centered design model, you're saying, what do we really need from primary care specifically? And it is a direct relationship, typically with a consistent primary care provider. That is where some of the greatest foundations for health and healing come into focus when you look at a lot of the statistics. So direct care is just that. There's no third party. We try to take out things that are not of value. So in design thinking, when you're looking at how to design a system, you're asking, again, what are the pains? What are the problems you're trying to solve? What are the gains for this human? Because it's a human-centered design. And if there is no value there, you're out. Show the value. What is your value? If you have value for your stakeholders, you're in. If not, you're out. So in doing this, we really look to say what is critical to primary care, and the majority of third party does not add any value. So when we say no third party, it's typically, like in our practices, is between the patient and the provider, but we can have a sponsorship, and that's the employers. So the employers can sponsor the payment model for their employees. But again, the relationship is direct. It's reoccurring, it's legislatively defined, and again, I'm happy to go through a lot of the information later, or if we have time for questions. This is just a nice little side-by-side comparison of what typical fee-for-service primary care looks like versus what a direct primary care looks like. Again, you're looking at a lot of very important data that is important to the stakeholders. And the stakeholders I keep coming back to are the patients first and foremost, but we also have to understand it's the providers and then anyone else paying in the system. So as we all know about the quadruple aim, we have to look at all of those as stakeholders. But as I think it was Jed, I apologize, I can't remember who said it now, was saying that now you're treating the health system as your patient. So again, knowing what the status quo is and how we can work with that. This just talks about the growth of direct primary care. It's not cutting edge, it's not bleeding edge, it's been around, it's a tried model that has been very successful and effective. The one thing that we are struggling with is scale. How do we scale it? And how do we scale it in a way that we maintain the foundational elements that are creating the success? So I think we have to be very mindful of that, but you can see where it's practiced. I talk about the quadruple aim. This, I'm just gonna go through these slides real quick. Again, these are some data information from a company called Hint Health, which is a software company that works with a lot of direct primary care practices. But it really goes to the heart of what we're looking for when it comes to primary care transformation. And the last column, and I'm not sure that's where my pictures of you guys are, but the last column is about wellness. And to Wayne's point about the social determinants of health, taking time to really connect with our patients. This is happening in direct primary care on a routine and regular sustainable basis. Again, this is one of the only transformation models that I have been involved with in my career that has actually achieved all four things on the quadruple aim. Because a lot of times with many of the other things, and as we were talking about before in some of the other experiments, we can hit cost and maybe we can hit certain patient experience things, but direct primary care has hit all four. So I love this too, because this talks specifically to COVID, that while the fee-for-service systems were really shutting down and delivering less care, direct primary care actually grew during this time period. So it was, I think, a pretty exciting piece of information to say that we were kind of pandemic proof, but more than the pandemic proof, we were able to maintain our relationships with our patients because we were all already on telehealth. And so there was not a blip in our care from direct primary care, which I think is really important. Let me just jump to the modeling. So what we created, so I have a direct primary care practice. Let me see if I can do this guy. I've been on so many Zoom calls, just as we were talking about before, but I haven't been the presenter for a while. So we created, so my partner and I started our direct primary care practice about 4 years ago. And it was very apparent to me that originally I was going to start with 9 practices, and I had funding and angel investors to do that. I decided that I didn't want to be in that situation. So started our own, and then we're going to grow from there. And that has been successful. So we created a network of direct primary care practices. We serve, my office itself, we have 2 physicians. We serve multiple small companies, but we knew that a lot of the companies coming to us said, hey, I really like this model. I want to offer it to my employees, but I can't say, hey, do you want to go see Dr. Mechley? You know, they need to have choice. And then working in a benefits model and under ERISA law, we really need to make sure that we're legally compliant and we are easy to use from a network perspective, but still different by design. I have had so many TPAs and brokers that are just get so frustrated because they're like, you're not off the shelf ready to go in our model. And I said, correct, because our model is different by design. And if we fit into the current model, it really does not make a whole lot of sense. And it's so funny because they call themselves innovators, but yet I shouldn't say that. There's a little frustration there, but they call on me because people know I speak about this and they want me to come to their summits and talk. And then when we get down to it, they're really not ready to make any significant changes in the status quo, as we were talking about before, because they're making a significant margin. So just as an aside, making sure that we're working with the people that are aligned and understand that the finances have to be there and then the care will follow. So sorry, I feel like I'm jumping around the place because I'm trying to be as quick as possible because I want to open it up to a discussion. What we did after opening for 2 years is we connected with a lot of the other direct primary care practices in the region. I'm in Cincinnati, and we started a network called DPC. So all of our docs are owned, but they're connected under one umbrella company, DPC, so that when we work with employers, we have a single contract, a single price point, administratively easy under one piece of software. We work with the brokers and the TPAs to make it part of their plan design. And again, I can tell you who we work best with. It's just simpler with self-funded companies that are probably 500 and less. But as we grow, we will be able to grow with that. But it was very apparent that we needed that network, and then we needed the ease of access to work with the companies and what they understood when it came to their benefits. So this is just one of our slicks that we pulled up with, and this is the one that we give to employees. So when employees are trying to understand what this benefit is, we try to describe direct primary care and that these are doctors that are working for them. And I brought this up because this last page basically says, this is what's under contract. These are the services that we consider advanced primary care. These are what's covered under your membership. If the doctors offer something else in their office, which they can do, it can be for additional casts. Like we do all of our own derm and do a lot of our procedures in our office, but I can't offer that under ERISA law because a lot of the other offices don't. And so again, I'm touching on little pieces I think people will be interested in. I'm happy to dive deeper in any of this because it's taken me 12 years to come to this place and learn from many others and develop the current model. So this just talks about why they would consider this and the services that are included. When we approach an employer or an employer approaches us and they're very interested, financially, and this is what I think Larry was speaking about, we have to kind of help them understand what this is going to do to their spend. One of the things, and Joe knows this very well, that when we talk about direct primary care models is that we can say there's going to be a 10 to 30% decrease in the total cost of care. Most healthcare reformation or transformations, you're hoping for a flattening of the spend if you're lucky, or instead of going up 12% year over year, you're going to go up 4%, and they consider that a success. I have to always point that out because people, it just gets lost in. We're talking about a 10 to 30% decrease in the total cost of care spend. So when I talk to employers, let me see if I can share this. Are you seeing a spreadsheet now, Larry, or are you seeing?
No, I am not.
Okay, I think I have to go back and keep doing that, share this screen.
Yeah, I think you have to stop sharing and then you have to reshare with the new.
Right, thank you. It says you are screen sharing. Oh, now we're back. Everybody say hi. Okay, spreadsheet?
Yep.
Okay, awesome. All right, so I ask employers, and I can work again, and some of the consulting work I did was with benefits brokers and benefit companies, because I was trying to help them understand where their high cost spends were and how we could alter that by the use of primary care. So you look at your orthopedic spend, your cardiac spend, et cetera. But I realized in doing that work, we just would take we would take the 12 months rolling average of a lot of their costs that most employers have. And actually the brokers have this and the healthcare insurance companies have this. And we get this through the brokers or the TPAs. And I ask them these 10 questions. That's all I really need. So we ask them, again, this is just the dates. This is their total spend. How many people are enrolled in the plan? How many spouses? How many enrolled children? And by the way, this is a case study. It's been blinded, so it's fine. Then their total cost in this dates that are covered of that $1 million, how much was spent in inpatient, imaging, radiology, ER, specialty visits, pharmacy spend. Then I take out teledoc, because teledoc is another PMPM spend that a lot of employers do. And they have to understand, and again, if you ever do an analysis for that, everybody says, oh, it's only $6 PEPM, which is per employee per month. But in most cases, it's ridiculous. It's like $3,000 to $4,000 for about 12 people that have used the service. It is just an interesting way, again, of this kind of back of the box, kind of using funds that people don't see where their money is going. So I always tell them we can take the teledoc out because direct primary care doctors are available to their patients, and it's their own doctor. So it's much better. Then they're not going to see any claims data from their primary care. So the PCP costs come out. So once I have all of this, I put it into a spreadsheet like this. And then I take this information and actually put it into a proposal. But I kind of wanted to show you guys the backbones of this. So in this case study, the company spends, $1.1 million on their total healthcare spend on 120 employees, 26 spouses, 32 children or dependents. And so if everybody signed up for, direct primary care, we're talking about 178 people. What I do then is say, okay, let's know that everybody's not going to sign up for direct primary care. So if 10% of your population signed up, 25% of your population, or 50%. So we know that that's the case. So we take those numbers and break them down. Then I take the current spend. So this is the data that I just showed you, the inputs. And here are some statistics from a lot of the different databases that have been, or the different research data on lowering the cost in direct primary care. So we know from the national data that inpatient care is reduced by 60%. Imaging radiology is 29%. This is where that 10 to 30% overall savings comes from. ER visits or ER costs down by 54%, specialty visits, et cetera, et cetera. So those are the percent decrease that you should see. And again, another really important point here, you see this in year one. When I work and you go in and we do a lot of work in prevention and lifestyle medicine, behavioral change, we prevent a heart attack in year 5 to year 7 approximately. A colonoscopy is a long-term spend. This is why this should be so excited to employers, because they're looking at this kind of spend in year 1. Now I say, okay, let's just say that we don't do as good of a job as we've seen nationally. So let's cut that in half. I always like to do financial, very conservative analysis. So we cut that in half. So based upon a 50% of what we see nationally, this is our estimated savings. So then this is the estimated savings in those areas from 10% of the population joining, 25, 50. This is what your CFOs, CEOs really want to see. They want to understand, okay, this is great, but where are the numbers going? So based upon this, this is the kind of spend that we're looking at, you know, the reduction in cost. Here's my monthly cost for you joining our DPC network for those for 10% of the population, 25% and 50%. Here it is annualized. So a very conservative estimate, if all you did was sign up for an improved primary care, and I always say different because I don't like to usually say better because that means there's a judgment call there, but of an advanced primary care model where we do know that patients get healthier and they have improved outcomes, right away, if only 10% of your employees signed up, you would have a 2.87% savings in year one, which translates to $33,000. 25, a quarter of your people sign up. Of these 178 people, we're talking 83,000. And again, only half of them sign up. We're talking about 166,000 for a small company like this that has 178 people on their health plan. So you can imagine where these numbers would go. So again, it's quite significant. What I show here is your primary care visits actually go up by about 50%. This is a high utilization type of care. We want to see patients. We make the guarantee that when patients sign up, you're only paying for the patients that sign up. There is no PEPM. I'm very sensitive about that because we only want to get paid. We only want to pay for what we're using. And then we guarantee that we get the patients in or at least have them make their first appointment in the first 30 days because we can't save money if we don't see them. Because that's what a lot of employers are typically have paid for in the past or things that maybe have not been utilized. So again, this is that pro forma that I showed Larry, what I do to help employers really understand and pencil out the savings in primary care. And then again, the discussions go on to a lot of other benefits for direct primary care, which I think everyone else here understands. So I'll just put a quick pause there because I'd love to hear feedback or comments or any other questions, because this is where I can get out and go deep in any aspect of financials, business planning for direct primary care, scaling, networks, all that good stuff.
Jed says he loves it.
Come be a patient. It's wonderful. It really is the best care that I've given my whole career.
Yeah, Cincinnati's a little far from Endicott, New York.
We've got telehealth.
Hey, my DPC doctor's in Utah right now, so you can make it to Cincinnati.
Is he?
I live in DC, so.
I've had people move away and they keep their memberships, and I always say that's great, but if you really need to be seen, but a lot of them will come back, once a year, twice a year.
So, Amy, this is Wayne. Can I ask a question?
Hi, Wayne. Certainly.
Hi. So this is great, and I think it is an illustration of what happens when physicians take care of a whole person, right? I mean, because they're taking care of the person and not just providing a service. So I'm just wondering, we have growing information that's pretty substantial, and Joe can validate this, is that you can not only save money in the management of care, but you can actually both prevent and even reverse many of the chronic diseases that walk into a primary care office if you incorporated, lifestyle, behavior, drugless approaches. To what extent does your model incorporate those? To what extent do your providers do that? Because if you're like my medical training, you didn't learn how to do that, nor do you have a team necessarily that knows how to do that or the resources. And if you need to address social determinants because your employees are, in a underserved area and, don't have access to food or transportation or things like that, to what extent does direct primary care do that in a formal way, and have you actually captured and documented that information in some way?
Yeah, Wayne, that's a great question, especially, we use I apologize, not your health note. What is the note?
Hope note.
Is the whole health note?
Hope,
Hope Note, yeah.
Hope
Right.
note. Yeah. The H was in my head. I'm like, it's not the health note, the hope note. So I have, so I'm double board certified in lifestyle medicine myself. And this was the model that allowed me to practice lifestyle medicine. So I'm one of the only board certified lifestyle medicine docs in the Cincinnati area, in the whole area. So I am a huge believer in what you're doing specifically, and have read a lot of your work, and cannot underline that more emphatically, that is where true health and well-being come from, and we need to recognize the power of that. And that's the slide deck that I was showing you was the one that I did for the American College of Lifestyle Medicine. So currently, one of the things I'm working on, which I think has such great power to scale, is lifestyle medicine providers have not been able to find a way to practice sustainable, financially balanced healthcare. They're trying to do what you're doing in a fee-for-service model, and they have just created a ton of workarounds, scraping by with some, modified G billing and, E&M codes, and trying to get the health coaching paid for, which is what I did when I started the wellness division at a large health system here 12 years ago. We kept trying to figure out how to get insurance companies to help work and pay for this, what we were trying to do, even though showing them again and again some of the statistics out of lifestyle medicine, which again, in integrative health, that are just profound. Healthy people spend less. It's just, we have that data. But as Michael Greger says, there's not a lot of money in broccoli, so it's really hard for the status quo to get behind it. So currently, one of the things I'm working on with the American College of Lifestyle Medicine is trying to create a curriculum and method for the doctors there to transform into direct primary care practices. I wrote a 20-hour curriculum for this because I get a tremendous amount of physicians who are saying, I want to do this too, teach me how. And they're like, I'll take you to lunch. And I'm like, no, this is like 20 hours of business consulting. You need to know how to sign a lease. You need to know what to look for in, you need to create a P&L. I mean, most of the people have no idea, minimal business background. And I get very passionate about this because if we're going to sustain this, we need to help support that. So the idea is to help current lifestyle medicine providers, which there is now 5,000 in the American Academy of Lifestyle Medicine, who want to consider a direct primary care model and help train them in that. And then all the direct primary care doctors, not all of them, but many of them who want to be actually doing this kind of work, but as Wayne, you said so beautifully, have never been trained and or are like, there's no way. I can't even talk to my patients about 2 minutes of smoking cessation. I just document counseled in my little box and I feel like I've done something. So then we look at our DPC providers and say, would you like to get board certified in lifestyle medicine or integrative care, et cetera? But lifestyle medicine is the area that I'm focused in, and the board certification, it's attainable and I think there's a little bit more of an ease of entrance, but
easier to get in, right? Yeah, that's right.
The way it's just kind of filtered out. So at a really exciting crossroads where once again in my career I see these things. It's so obvious to me because the DPC is the financial model. It's not a clinical model. It's not the way you practice medicine. It's the support model so that you can practice. Right. And I get a question from the ACLM group all the time. Well, what can I create a DPC that I can have health coaches? Can I create a DPC? I'm like, you can create a DPC that is exactly what you want it to be. You just have to you just have to have the business model to support it. So if you want a health coach in there, you have to create a financial model that covers that health coach's salary. And how do you do that? It's a revenue model. So it's just really sitting down. So the exciting part is you can do this. You just have to be very transparent about your value. So patients say this makes sense, or the employers say this makes sense. So my practice, I have patients about 15% are Medicaid. I would say about 40% have no insurance at all. So in my opinion, they're well underserved. And then a large portion of my commercially insured patients have $6,000 to $10,000 deductibles who I consider underinsured. I mean, because you really don't have insurance until you spend $10,000, and the majority of families never spend more than $2,000 in a year. Again, it just does not make sense. So,
so the DPC really, is it fair to say that the the basic financial framing for DCPC is the term you used at the beginning of this, which is global financing for people. You got to build a global financing package that you can sell to whoever the payer is.
Right, but it's only for primary care. So I believe in catastrophic care. I do not use my health insurance to,
That's right.
to clean off my, I don't use my car insurance to buy a new battery. I don't use my car insurance to buy gas. So catastrophic care needs to stay catastrophic. As Len, I think, said earlier, the difference, I wrote it down, I loved it, the difference between investment and payment. And I apologize, I think that was, I don't remember who that was, but I wrote it down.
That was Jed.
That was Jed. Thank you, Jed. Thank you, Jed. Yeah, I mean, it's a flat fee. So it's the key factors here are transparency,
Correct.
budgetable, a flat fee, all-inclusive advanced primary care. Our patients don't pay no matter what. If they telehealth, they come in, et cetera.
Right. So the payer still needs to purchase some type of, or the patient still needs to purchase some type of catastrophic care and specialty care, right? If they need a knee replacement, then they're going to have to figure out how that gets covered, right?
A true catastrophic plan, right?
Knee replacement isn't necessarily catastrophic. It might be part of routine care, but it's specialty care. It's not something you'll do in your primary care office.
Right, but it's an insurance-based model of care, right? It's for the big ticket items.
So you need 3 layers of payment. You need global payment for primary care, you need catastrophic care, and you need routine specialty care.
Well, in an employer model, again, that's working with what's called the plan design. So you do a carve out for primary care, which takes 10 to 30% cost of care down. You reinvest that, and you actually right size your catastrophic care with an umbrella stop loss. And you very quickly have all 3 for employers who are self-funded. For an individual, the way that a lot of my patients do and what I do is I have a health sharing ministry type of backup. And, and then you can get an HSA with a very minimal MEC plan. So there's multiple ways of doing it now, but it's cumbersome because you're taking out a lot of the middlemen that don't get a lot of value. Yeah.
Doctor,
you got it.
This is Joe. Just out of curiosity, why use the nomenclature of designating between catastrophic care and specialty care? I mean, could those be just grouped as non-routine care from a patient perspective, right? So if routine care is primary care, it's the daily nuts and bolts of how do you take care of yourself? How do you maintain your body over time? How do you maintain your health and totality of health over time? But a knee replacement from a patient's perspective, I sure hope as hell is not routine. Versus for the health system's perspective, it may be routine, and insofar as it's not an absolute urgent, is quote unquote elective, but it falls into that same bucket of, hopefully for a patient, it's a once, maybe twice in a lifetime occurrence, like a car accident, it's a once in a lifetime occurrence.
Good point. Yeah. So 2 bundles would be the best way to do it. Yeah.
Right. And Wayne, I think you were separating out something that's more elective, catastrophic, meaning like it's truly accidental.
Well, I use that because that was your term, catastrophic, but I like what Paul said is it's really about routine care, prevention, chronic disease management. Primary care is what that is. And then there's the other stuff that people need every once in a while. So,
right. Right. Yeah. Which we will, if we do the first part better, we'll need less and less, which is true.
What I hear you saying in the lifestyle area is that there's a training or an education gap where the lifestyle people don't know the business part and the business people in direct primary care don't know the lifestyle area. And so.
Could I actually add a third gap to that? So I have a really good example of this. So part of the training and education that needs to take place is with patients, right? So you can have the best, you can have Joe Scherger be the doctor on call, on hand, but if the patient doesn't really get it, then it doesn't matter if it's Joe Scherger, right? And I was just talking with one of my friends from college who's now, I think, just turned 35, and I've been working on him for years to get a direct primary care practice, and he finally signed up with Forward Health. And I have him on record on a podcast saying, I finally get it. I finally care about my health care. And I finally understand why you've been saying I need to talk to a primary care physician. And I care about my metrics. I care about my A1s. Like, I care about my lipid panel. And it's like, before signing up with Forward Health, he never had an opportunity to talk to a doctor who had the time to actually explain why it matters. Even as at that point, 34-year-old, single male, living the dream. But he talked to one doctor, and they had the technology, and Forward Health is a very tech-centric platform, and kind of gamify everything and make it app-based. But it's still the same stuff. It's still, how do you make a patient care about their own healthcare, even if they feel young, healthy, and invincible?
Yeah, no, that's right. I agree completely. I mean, we have brainwashed the entire culture into thinking you've got to go see your specialist doctor if you want health, right? And get the latest drug. It's a cultural framing that is wrong, but that's what people believe when they go and see their doctor, and it's what most doctors offer. So that's reinforced.
Absolutely. And if you don't get something, why did you copay? I hear that so often. That is one thing I've taken at the AAFP to task, the American Academy of Family Practice. I have been every juncture have a moment with any of the leadership. I say, I think your first and foremost job should be to educate the public on the value of primary care. And I know they've tried to do it in a few different ways. And with the resources that they have, I just feel like there has not been a very effective value proposition put forth, and stories. And we all know that how people change behaviors. It's three-part. There's data, there's stories, it has to be personal. I think, like Joe was saying, if you've got the shiniest, prettiest penny out there, but nobody sees its value, that's why, again, I had to go to these type of, because I was like, oh my gosh, this is great. You get a half an hour, 45 minutes with your doctor. Crickets. I was like, no, really, you get a half an hour, 45 minutes with your doctor. Crickets. I was like, huh, that's not, people aren't quite getting that. And then when I call it the shoulder drop, my patients come in, and within 10 minutes of me sitting with them, I just watch their shoulders drop. And I wait for it, and I watch it. I'm like, there it was. I'm like, they get it now. They're relaxed. They realize I'm not going to be looking at my watch. I'm not going to be standing up. I'm not going to be typing on my computer. And then they walk out there going, I've never had anyone listen to me, or, so.
Yeah,
I
isn't that sad? I mean, it's great, but it's not sad that is so rare that happens. Yeah. Anyway.
Jed, I wonder
Amy,
if
do you have a recorded version of your presentation?
Yes, as a matter of fact, I do.
Yeah, that
this last year, yeah.
Yeah, that would be fun if you could share that, because there are places I'd like to socialize that, particularly if it includes the financials that you shared.
It doesn't. The last one that I was just thinking of, Jed, is the slides that I just did, and I did it in 15 minutes. And it was just about lifestyle medicine and direct primary care, how that financial model should really work well with lifestyle medicine. What I showed you my financials is just my own personal business for the network.
Yeah, well, if you could make it more than your own personal, that reinforces and actually is a nice glide path into what I call calculating the future value of primary care from that standpoint, because you speak to the real dollar impact. There's a fair amount of that analysis in the FMA health stuff, but you really have put it in a concrete fashion, and you represent the realistic notion that not everybody's going to opt in the first go around. But your information around the teledoc thing and the wellness thing speaks to what I share with employers, is the opportunity to spend the same or less money more intelligently.
Yes, smarter spend.
So, and before I forget, do you know Jeff Moore?
I don't think so.
Okay, I'll digitally introduce you to Dr. Moore. He was one of my early mentors when we created the Cornell program for healthy living back in 2010. He referred to himself as a recovering internist. in lifestyle medicine. And, you know, so I'll introduce you to.
So I'm going to mention to the group, because I know Lauren has to go here in just a moment. We originally, the plan was to have Amy present and then to have Jed present. I think we need to just continue with this conversation. And Jed, if you're okay with it, we'll have you present the next time.
Absolutely. I'll get a bigger wine glass too. So.
Good wind up. Yes. Good
I'll
wind
get a
up.
nice glass of wine. That's a good idea.
Lauren,
I
thank
didn't know
you.
that was a prerequisite.
Scott, it's good to have you join us. Okay. So
Scott, you're muted.
I said it's great to be here, and I'm sorry I was late, Amy. I really was hoping to hear the whole thing, but I just got back from work and jumped on as quick as I could.
So we're recording the conversation, Scott, so you can watch it at another time. So other questions, Pat Tokars, you look like you were a question was forming.
Well, I really, number one, I'm thrilled, Amy. I think you did a great job presenting. Even though you jumped around a lot, it was hitting high points that were really exciting to me, and I think to Jed as well. You know, we've all seen different pieces of this from different perspectives, and you really pulled it all together in only 12 years. I'm impressed. But my real question for the rest of the discussion is, you opened with the challenge of being, how do we scale this up? Not too many physicians are going to be as dedicated to you, to this vision, to follow this over 12 years, understand the mechanics of the financing the office. How do you make the numbers work? How do you present the information to self-insured employees? How do you make this work for Medicaid patients? Medicare patients is the largest and growing segment of the population. You know, how does this get adapted to Medicare? Unfortunately, knee replacements, Wayne, and hip replacements and shoulder replacements become pretty much routine care once you start looking at Medicare patients. It's just, you know, there's so much we can do for prevention. We can postpone things, but the body still is going to gradually fall apart. So I think if you're going to scale this up and try to look at this as a solution beyond the self-insured employer, which I think is the best fit initially. And maybe Scott, you have some experience with this. How do you adapt this financial plan is my first question. The second question is, how do you clone Amy Mechley? Because, you know, you could, if you could save your employers 30%, you could get a whole lot of people saying, yeah, I want more of that. But Scott, as you know, you can't just all of a sudden go, well, here's 100 DPC docs that are ready to start taking care of your, you know, X thousand patients. And individual DPC docs are individual DPC docs. Most of them go into it because they're violently individualistic and they don't want to follow the norm. So how do you herd your cats once you're trying to give a fairly uniform approach? How do you get people who never heard of lifestyle medicine, as Wayne said, to understand it and to embrace it? How do you start to integrate behavioral health into primary care, which is like the next big quantum jump in terms of cost effectiveness? You know, over 50% of what we do in primary care has a huge behavioral health overlay. And most of us had to ignore that because we just couldn't afford to ask those questions and deal with all the worms that come out of the can when you ask those questions. So I guess what I'm saying is we're all eager to figure out, how do we solve these problems? I think Jed has some ideas. How do we create a curriculum for the clinical aspects? I'm very excited that you've put together a curriculum for the financial and the dollar aspects. And I think with Wayne putting together the program for you know, the integrative approach towards holistic care, but how do we get this up to scale is the question.
You know, Pat, that's an excellent question, and that's, again, if And I always thought about that. I'd be really happy just to go off and do my little own thing, and my husband would be very happy. And as Larry knows, I have never stopped because I keep seeing places to lean in. So that is the goal. And what has happened thus far, I can say what, you know, and I always say this isn't the answer, this is a answer that we all can build upon. But there are already multiple networks across the nation, some multi-state. We're in 3 states right now, our network. I do believe in the value of most primary care doctors having a stake in their own practice and not being employed. I've just seen it. And again, that's cultural. Can it change? It's possible. But I like when doctors have their own practices. So what we've created personally is everyone runs their own practice, but they come together under an umbrella to do those offerings for the employed patients. So that has been very effective for our growth, because we are I would say we're in the 2nd generation of DPC doctors. The 1st generation was lots of things, you know, the man, screw it, you know, whatever explicative you want to use, and I'm up to here. And the 2nd generation now is out where they're saying, I like the way I want to practice medicine. I want to be doing the kind of medicine, the primary care that I want to make sure is best for my patients, because we're still under the same guidelines. And I think the 3rd generation might be coming very quickly post-COVID. We've already added 2 more docs in the last 2 months who, for multiple reasons because of COVID, are leaving the systems, and we're going to have a mass exodus. I just found out that one of our large systems is releasing their primary care physicians from their system. That is going to be massive. Yes. So I don't want all those doctors by any means, because to your point, you have to be invested in this. So I don't think it's the answer. I think we still need to have multiple types of primary care available. But from a payer perspective, when I was working with the state under the Medicaid model, that's one of the things I actually did talk to them about, and the people that are there have since dissipated, but I still think it's worthwhile, is to have a simple voucher program. You have a voucher program, it's transparent. You have this many dollars to go spend on direct primary care. You choose, it's patient-centered. The patient is the consumer. They should be able to leave the practice. They should be able to find their own doctors. They'll accept whatever that voucher is. And then if the patient wants to go somewhere that they charge more, there is possibly that open transparency to that. But I think there has to be some guidelines to saying, here is what primary care, here is what the investment, to use the other term, in primary care should look like to maintain a successful practice per person per month. And it's very transparent, and that's what we work off of. And my overhead, so primary care providers overhead, 40% of my overhead went to working with the insurance model. So of every dollar that I brought in, 40% was out the door because of billing, documentation, insurance, working with coders, all of that. I take that back and infuse it into my practice. My costs come down considerably. So again, the finances that work for this model work across the board. But Pat, I think you make some really good points, is how do we maintain, it's almost like a franchise. How do you buy into that, but yet maintaining some independence? So I've already seen some bad ways of doing it, where there's some networks that are employing nurse practitioners. And I think nurse practitioners are fantastic, have trained well and work, you know, kind of as an apprenticeship, and then they go out on their own. But currently they're training. I can't understand why they train them the way they do, and that'll be another subject. But it's not a strong model. Unfortunately, it's not what I think is going to be successful for what we're looking for. So I don't want to go on too far, but there are already ways of scaling. I am very excited, like I said, about this, the lifestyle medicine and the DPC coming together, because I think within 2 to 3 years, we could have 5,000 to 8,000 more direct primary care practices that may be trained in a lifestyle medicine model. It's not that far off, because of what I know, what I think we can scale, and how people can become trained, how people can be trained in the clinical model, and how people can then be successful in the financial model. And we shepherd that. We don't let them take 12 years. I mean, I took 8 years to do my business model before I opened my doors. That's because I did it, you know. And now I can give somebody that in less than 3 months. and they can learn. And I just got 2 more emails from 2 other docs saying, hey, we want to do this too. Can you sit with us? I'm like, no, I really can't. I want to. So we're trying to create this curriculum so that they don't step in any landmines, so that they are successful. Because when they're successful, it's not a competition. This becomes the norm. And then transparency and direct care become, this is the way primary care should be. So sorry, you got into a little bit of my philosophies, but did I answer those questions that I think you had like 6 or 7 questions in there.
Well, you certainly approach the answer to the business part and the financial structure, but Jed, I wonder if it's premature or time for you to tell us a little bit about your vision of the curriculum for the actual clinical skills and practice.
Well, Pat, it goes to what I referred to earlier as calculating the future value of primary care, in the sense that we need to be able to identify for the purchaser the broadest possible scope of services that primary care can deliver. And in order for them to think differently about how they buy healthcare, the simple truth about self-funded employers is they don't buy insurance, they buy healthcare. And how they organize their benefit plan is their decision. Often, though, they don't buy things from primary care because they don't think primary care can do certain things. And Amy, to your point, wellness is a perfect example of that. So what I've been doing in collaboration with the Texas Academy of Family Physicians is creating a purchaser-driven business model that supports primary care by helping to identify, in terms of buckets of service, what primary care is capable of if given the opportunity, either to deliver a certain service directly, or Amy, as you pointed out, expand the care team in order to be able to deliver those services under the guidance of a primary care physician. And so that's been the approach that I have used in order to simplify the conversation and to move self-funded employers, purchasers, as far away from CPT as I can, by talking about, and again, I'll steal my thunder from the presentation that I've been sharing with employer coalitions and the like, is the 5 buckets of service being preventive care, wellness services, disease management services, care management, care coordination services, and finally acute care. And with the exception of preventive care and acute care, it's not surprising. Employers had never thought about buying wellness from primary care, disease management from primary care, or care management, care coordination support from primary care. And so that's been the focus of what I've been working on in order to create this clinically based validation for the purchase of primary care differently, and frankly, and most importantly, on the basis of a comprehensive payment. Because Amy, many of your colleagues would run, the early adopters of direct primary care would run around talking about how their services are less than the cost of cable. And I would say, okay, what does that mean? And how is that really a statement of value? So I understand from a consumer perspective, they were trying to, peg it to something that folks buy anyway. But I thought it would be more important to create a true business to business conversation based upon the way purchasers buy healthcare on behalf of their covered individuals. Pat, I'm not sure if that's what you meant, but
I was actually trying to get past the business structure and on to the actual clinical skills and the philosophy. In other words, I was trained at Hershey just before Larry got there on preventive medicine, wellness, disease management, care management, coordination, acute care. But in my first 20 years of practice under fee for service, I was only reimbursed for acute care, basically. And I tried to squeeze a little preventive medicine in there.
Oh, yeah. No, and that's why I asked Amy if she knew Jeff Moore, because that was the world that Jeff had perfected the art of the group visit.
Mhm.
In order, and in particular, that's where he did most of his best disease management work, was in a group visit. And so yeah, and so that's the other element of this is to help a purchaser understand that primary care, when given the opportunity financially, would be great at dealing with stress, diet, exercise, and sleep. Wouldn't that be fun if the purchaser could buy help on behalf of their covered individual for matters related to stress, diet, exercise, and sleep? So really, it's intended to create a clinical opportunity for primary care, where previously it was outsourced to some vendor and the purchaser was frustrated as to how come none of this is working.
Right.
Well, because you're fragmenting it, and in some cases you're causing it to compete with each other.
I remember, Jed, to that point, United Healthcare had a great statistic, and this was 2016 data, that was approximately $758 per employee was spent on wellness. And I was like, that's almost a year's membership in my direct primary care practice. That was what they were spending for the vendors and the companies to come do, lunch and learns and give flu shots once a year. And they're wondering why their costs didn't go down, and they called it their wellness program. It's just really helping the purchasers understand what they're buying and where that money is going, and how effective for it to come from a trusted resource for that patient, because healthcare is local, to talk about, what Dave Chase is talking about. If a nurse calls me from United Healthcare to remind me of going to get my mammogram, that call or that notice is going to go just undone. And they didn't really understand that. That was about 10, 12 years ago when I was in that health system doing the wellness programs. That was a key element. So I love that you're trying to help educate the buyers, the purchasers, of saying, this is proven to be very ineffective. Please stop putting.
Yeah, stop wasting your money with both hands.
That's a lot of money to be wasting. These healthcare dollars are precious. Yes.
Yes, absolutely.
Yes.
And so the business model I'm working on suggests that 15% of the total cost of care should be primary care.
I've heard that before, and
based upon current
6 or 7,
stats,
right? Mm-hmm.
that's about $90 a month for a commercially insured individual, if you will, or a commercial person, not a Medicare person, not a Medicaid person, but a commercial person.
Right.
And so by looking at it in terms of those 5 buckets, you get a bit of an aha moment from the purchaser that goes, oh, well, if I include those things, well, yes, you should include those things, because right now you're spending money on those things with very little to show for it.
Right.
And you're complaining every day.
And poor metrics. Yeah.
Well, no metrics often.
Right. So the financial model that I showed you, we're at $80 per month, just for adults, and we're at $50 for kids. So just that helps with that financial model.
Which makes it like the fact that employers are purchasing it to Livongo at $68 per member or per employee per month.
Yes, perfect.
Yeah.
That's it exactly.
Right, and $3,000 on Teladoc for 12 people.
Yes. Yeah, because they're not able to engage with folks. And I've seen the growth that you illustrate in your spreadsheet simply based upon word of mouth.
Right.
Mary tells, Johnny how wonderful this damn thing is. I should have done this a long time ago, because now all my health literacy confusion is gone.
Or Jerry tells Mary about, I just got a bill for $800 for the urgent care visit that, didn't work out all that well. And and they're like, well, didn't you talk to your direct primary care practice? And they're like, what are you talking about? That's the conversion that happens. And I usually tell employers, I only want 10 to 12% of your employees the first year. And they're kind of like, what do you mean? And I said, no. I said, if we get, for some companies, we get like 30 to 40 to 50, which is great. But I said, because I only want people that want to be there. And then they're going to hear from so-and-so, then they're going to go, I want some of that. It's not because my employer made me switch doctors, because we don't really want we don't want the employer in that situation, and we don't want the employee to feel like that this is their only choice. I said, I only want 10 to 12%. And then, year over year, we grow, and people are coming in saying, yeah, Mary told me about this. I need to start this. And then that's the fun thing in a self-funded plan. We can start people at any time. We don't follow insured rules that you can only sign up at a certain time. It depends on how the plan design document is, but we're a true carve out. You know, we're there to serve people. Anyway.
Yeah.
Michael, you were there when the first statewide network of DPC practices in Rhode Island about 8 years ago. What's the update on that? Because it seems like that would have been a model for a regional network.
I'm drooling. That was more like 13 years ago. And I just admire the work that I just heard about. Our challenge was that we couldn't get employers to sign up for it because they thought we were nuts, and that we we didn't have anything like an insurance product to work with. But we put together 20 practices and 50 docs, and you know, it looked on paper like we were ready to go, but I think we were just too early. And we topped out at about 700 patients altogether, spread over those people, you know, and I kept dreaming that we would be able to fill a couple of practices, but just we never got there. And so it fell apart over years.
Let me understand that better. So the 700 patients, did they have dramatic savings for their employers, and was that not enough to sort of have this thing grow? I mean, if the plan works, you think it would grow and be successful. So why didn't it?
Well, we never got to employers. You know, it was 700 individuals. And
okay. So there were no self-funded employers making the decision.
there were no self-funded employers. We tried and tried and tried, mostly working with insurance brokers to break into that market. It may be that the psychology of Rhode Island is such that everyone is just too tied into Blue Cross, which was kind of part of the deal. And it was also early in the transition to self-funded employers. Now we're, I don't know, 45 or 50% self-funded employers, but then I think the numbers were way smaller, and that small employers wouldn't go near it. And that probably, you know, kind of closed off the opportunity at the end of the day. We were well, but too early.
If I can offer a comment, I'd just like to reinforce that. I was out there with you with Health Access Rhode Island, talking with you and learning in the early years. You were ahead of the curve. You were definitely one of the innovators. And I absolutely agree with you. You know, and what I've been watching in terms of conversations with employers, most employers still, it's just beyond their ken. They just don't digest it, and it does not absorb. It's beginning to. Some of the healthcare coalitions, Pacific Business Group on Health, et cetera, are beginning to understand, but even their individual employers are trailing far behind them. So I think it was too early in a number of ways, although it was a brilliant model.
It sounds wonderful. And the other thing that I think is a really good learning point on top of that is, and Michael, I like how you pointed out, it was, you know, they might have been too invested in the Blue Cross Blue Shield mentality. I found that I have continually been undermined by brokers and TPAs who say, like I said in the beginning, they want to be innovative. And then, you know, their question is always, what % am I going to make off of you? And I'm like, well, you're not. This is, you know, and I've tried to help them understand that this is a client retention and recruitment. And obviously their whole job is supposed to be to save money for the employer. But as we know, the back end of that is not really true. So looking again and following the finances, I have found that if I have a really interested employer, I will ask them straight up, are you willing to change brokers and TPAs? Because they will not work with you. They will undermine at the last minute. And I've had many 8-month projects come up, and when they're ready to renew, the broker comes in and says, you know what, we're just really not ready for this. This is too difficult. I'm not going to be able to get the data. I'm not going to be able to, and I'm like, whoa, I can work through all of that. So I have found the status quo to be extremely powerful. But where we are now, and Michael, to your point, the timing of this, I mean, you had this idea, it's the same idea and you had some of the infrastructure. Now we're really looking at certain brokers that are actually willing to be transparent, and TPAs that are truly ready to set up a plan design that is effective and for the benefit of the employer, which sounds almost ridiculous, but wasn't easy to find. I'm actually helping start a brand new startup here in Cincinnati, a whole new TPA system that is DPC centric. And I know 2 or 3, and that's the thing, the employers have to understand that their TPA doesn't have to be in the same city as them, but it's not easy to help them let go of that. Especially, I mean, I always get, oh, this is great, but you're a doctor. And I'm always like, yep, I know, so it's funny how I have a foot in both paddles, but I'm not a trusted resource because I'm not a broker. And I just find that, I mean, I didn't get it at first, and then now it's very obvious to me, and because of that status quo. So I think we have to be very mindful of that as we're looking at scale, to making sure we know and understand.
Amy, how do the brokers and the TPAs earn money when you're talking about this next level? How does that cash flow?
The brokers that you want to look for earn a commission. They should be consultants. And that's one of my first questions is how do you earn your money? The majority of brokers will earn their refunds and their kickbacks. So if they sell 20% of their Anthem and they keep their book of business at 20 to 25% of Anthem gives them a kickback, literally. And
in those years, in the years we were working, Blue Cross paid 17% of premium to the broker.
Oh my word.
Which was incredibly painful because we were begging for 5% of premium to fund primary care. And that, that's why that question is such a perfect question, Pat, because it gets at how the system maintained at least itself. And I don't know if it still works exactly like that, but I know that when we got around in Rhode Island to setting up the health insurance exchange, the first thing that the person who was doing it had to figure out was how to deal with brokers. And the first thing she ended up doing was keeping the brokers, because that was the only way she could make the whole process work. They're a very powerful piece of the process. I still think, and Jed, you may know more about this than I'm sure you know more about this than I, but we really need some national insurance company for DPC, for the DPC process. We need an insurer who's willing to provide the high deductible major medical done in a way that supports DPC.
There are some out there, actually, Michael. There's one in there's a new startup in Colorado, but they're TPAs. Yep. Because a TPA just adjudicates, especially for the self-funded employers, and we don't need. So the TPAs will get an umbrella plan or a stop loss plan, and then if they're self-funded, they can just do it internally. But a lot of the TPAs, what happened is the TPAs will use an Anthem product or a Blue Cross Blue Shield product for their network. So they'll say, I have got all my specialty care and catastrophic care under Cigna or whatever it is. And then it actually inverts from a self-funded plan to a more of a high cost capitated plan, because you're really not getting that savings. So it is in the details, and it is behind this black box. Do you all know about Health Rosetta?
Yep.
Okay. Or Rosetta Health. I apologize.
Health Rosetta.
It's Health Rosetta. I question myself every time I do that. So unfortunately, some of those brokers have gotten in there just to get the name only. But if you find some true Health Rosetta brokers that they are committed to a transparent plan design. Oh!
Yeah. Yep. There we go.
So there what's funny is there's something in the water with a major national carrier. So in the past month, I've had conversations with one major regional blue in the Northeast, and then one of the major national blues, and they're all responding to the same market incentives, trying to figure out how to make an employer-sponsored advanced primary care model work. And of course, the larger ones all got distracted by United Health's play, and they're looking to effectively try to replicate like a Village MD or a Chen Med type model. Only they're trying to transpose it from Medicare Advantage into the commercial health space, which is not going to work, right? It's just the spend's not there. But there are some startup insurance programs. I actually have a call with a guy out of Atlanta next week called Eagle Health Plan that's looking to do exactly what you're talking about, Dr. Fine. But on a separate note, it is thanks to calls like this that connections click. And for me, I just have one of those weird aha moments. And Dr. Fine, you're laying out your timetable about trying to talk to employers 13 years ago about truly advanced primary care. And to give you a sense of the scale of just how far you were ahead of the curve, 13 years ago, 14 years ago, I guess now, maybe, I was talking with Peter Lee, who is the past president and CEO of the Pacific Business Group on Health, trying to convince him that patient-centered medical home was worth looking at, that level of investment in primary care was worth considering. And he was blowing me off. Like, so if you're talking about direct primary care and like true payment for primary care, like the employers were not even, the quote unquote innovative employer groups were not even at the table then. And we were at the Patient-Centered Primary Care Collaborative 13 years ago. We were struggling to talk about, hey, like, how about a $5 PMPM? Like, wouldn't that be nice? So yeah, so it's not shocking to hear that when you went to the employer community and we're like, fund primary care at value, that they just, I mean, those words probably just didn't compute. It was like auditory dyslexia.
Yeah, we're now at 9:30 Eastern. So I think we need to bring things to close, but if there's any last comments or reactions, and again, this is being recorded, so it can be shared.
Yes, I actually have one, and I apologize if it opens up a can of worms. So on the question of scaling direct primary care, this is clearly something I deal with a lot, right? So internal to the membership of the Direct Primary Care Alliance, we inevitably have someone percolates up and say, hey, why doesn't the DPCA form a network? And you have a reactionary force saying like, network is a dirty word, we can't do networks. And actually one of the things that I wanted to ask Dr. Mechley about is this idea of a voucher. So I and a few members of the DPC Alliance approached an employer benefits company. It's Zestful is their name, but what they do is offer effectively cash reward programs for employers, like, hey, get a gift card to pay for a monthly gym membership. So it's all post-tax dollars, but looking to set up some kind of unified funding mechanism for direct primary care services that employers could buy into, not necessarily with pre-tax money like an HSA or an HRA, but at least have something where a small employer of 50 or fewer employees could say, we will buy you, we will purchase a $75 discount card for you to choose any direct primary care you want, as long as it's part of the DPC Alliance. And that's just the hat I wear, but really any DPC doctor. And here's the value proposition of a DPC doc. This is what it looks like. These are the benefits for you and your family. Unfortunately, that right when COVID hit, that benefits provider, our contact there ghosted and left to a different company. So I'm trying to find a new financial vehicle for that. But I mean, that voucher idea truly provides some of the context of networks without necessarily bringing in the cultural baggage that the DPC movement still has, despite the fact, to your point, that we're seeing a generational iteration in terms of culture and what people anticipate and expect, and kind of what they deem as independence, capital I independence, for doctors.
Joe, I'd love to talk to you about that because you can do it. I'm happy to give you all the information that I have. You can absolutely do that. And you really honestly don't, if you want to invest in it in DPC Alliance, you guys could do it. you have to be very careful about ERISA law. So you have to stay under 50 to do something like that. Over 50, that's where I've gotten into. That's why we invested in all the legal aspects and the single contract, and that I had to create an LLC with affiliates. It does not cost my doctors at all to join my affiliation, period. I don't want it to. And I can fill their practice with employers. So so the value proposition is absolutely there. But yeah, I'm happy to, that's what I'd love to get into, is talk about more of, let's do this because it's happening, and we want to make sure that it happens in the way that I think it's fostered and the foundational pieces are sustained.
Joe, you're waking up old ghosts that live someplace in my soul.
I love it.
But I still think that finding that magic employer is important to sort of go down the road. Not that magic insurer that will do the high deductible gets at your idea, and it gets it in the following way. The way I always thought the way to fund the DPC piece was to fund it on the back end of a high deductible insurance purchase. So when the person makes a buy, they're putting in X number of dollars and they're getting high deductible insurance and primary care all for the same dollar, all for the same purchase. And they don't see that money exchange. That money goes right from the insurer to the DPC practice. I think that gets the value piece kind of stuck together in the way that people need it, because they need the financial protection in case of illness or injury. But they also, to have primary care feel like it's free as part of that is, I think, a magic opportunity. I just could never make it work.
This is a great discussion with a lot of terrific ideas. I guess, Amy, when you were talking, you started with the whole idea of scale. Joe just brought it up again. I think it's key in terms of how I look at the world of empowering advanced primary care, DPC. It has to be about scale. When we look at decisions being made about large amounts of capital being invested to build an infrastructure out that DPC can take place in, the committee that has to say yes, I'm one of 5 votes. I've got to convince 4 other people. And we have, in a parallel way, without talking about DPC, done this to get things to scale when you can put together 3 to 5 healthcare professionals in a location and then connect them to 3 to 5 others and 3 to 5 others. When you do that programmatic approach, it works, and we can do it. And that will work with DPC. So it's exciting to hear that being worked on. I 100% believe that every day we go forward, there are smaller and smaller number of employees at an employer where it makes sense to do self-funding of their healthcare benefits. And that keeps shrinking and shrinking and shrinking, so that the pool of employers who it makes sense to do this as a self-funded plan keeps expanding. And that's nothing but good for the future for these efforts.
So Len, I'm sorry, let me clarify. You're seeing the self-funded pool expanding or contracting?
Expanding, because the number of employees that it takes to be at an employer,
got it,
for it to make sense to do self-funding rather than have a third party, an insurance plan, traditional insurance, take the risk. That number gets smaller, right? It used to be 500 employees to make sense. Then it was 300. Now it's 100. And I think that's going to continue as technology gets less expensive, and the things you have to do to self-fund, reinsurance programs, become more targeted. And I 1,000% agree with you about what you said about the broker world. And I think Scott would say the same thing. We need to have this whole rethinking about how that works and what the alignment is that we need to seek with that, rather than the misalignment that's been there, historically until now even. And I'm in the middle of Dave Chase's book, Health Rosetta, is actually a great example. He's doing a live interview tomorrow morning on a national podcast. I think it's too late to sign up, but they make it available after the fact. And maybe Larry, I can share with you how people can click into that.
I've looked at that, but I just don't have the time right now to do that. I do try to tune into a lot of the stuff that that Dave and his team are presenting. So I'm going to use this as an opportunity to bring things for closure. Amy, thank you very much.
Thank you,
Wonderful
Amy.
presentation,
Brilliant.
and clearly looking at the reactions and the dialogue that it stimulated. You're really doing very important work. And I will say this for the FMEC and for myself, if there's anything that we can do to help move this forward, you know, you and I will talk some more, maybe with a little wine. Maybe this time I'll bring glasses with me, but I don't mind drinking out of
Don't
the.
break the tradition. Yeah.
I know. That's a kind of a cool thing. So, but I would love a chance to talk some more. So everybody is now connected. You all have each other's email addresses. If you need anything to help you connect with anybody in the group, please let me know. This conversation, as I mentioned, has been recorded and will be available. It's a long one, but for those who are really interested in the issues that we're talking about, which I think go well beyond direct primary care. I mean, it really is about restructuring the U.S. healthcare system. And, you know, hopefully a lot of people will want to take the time to listen in. Any final comments before I pull the plug? Pat?
Where do we find the past recordings? Recordings of
I'll
past
send
meetings?
you. So I haven't recorded all of them. I've recorded a few of them, but I will send you a link to those, to everybody.
Thank you.
Yeah.
Thank you all for everything. This is very invigorating.
Thank you. Likewise.
Live long and prosper.
Thank you. Yeah,
Thanks,
thank you very
Larry.
much.
Good night, everybody.
Bye-bye.
Bye-bye.